I've been called to a 55-year-old male who's in cardiac arrest. He's received the following treatment from an ILS crew who has responded prior to my arrival. I've been responded as the ICP. This patient is indicated for intubation. The indications for intubation for a standard ICP that is not RSI trained is a GCS of 3 and ineffective breathing. This patient meets both of them. Another scenario in which the patient could be indicated for intubation would be for a traumatic brain injury where we can't ventilate, we can't oxygenate, there's no RSI available. It's dangerous in this circumstance, but if we can't oxygenate and ventilate, then we've got nothing else that we can do. In all other scenarios, RSI would be most likely indicated as the risks generally outweigh the benefits of intubation. So firstly, we're going to go ahead and position this patient effectively to achieve intubation. This involves aligning the oro, the pharyngeal and the laryngeal axes so that we can reach anteriorly to get the cords. And this would involve the sniffing position, which is the alignment of the sternal notch with the tragus of the patient's ear. So I'm going to go ahead and do that now with some towels. Alternatively, you could use a pillow or any other objects that are on scene. If nothing was available to you, you can use your boot underneath the patient's head. Cool, so I'm happy with my position that the tragus of the ear is in line with the sternal notch. Another thing to consider is if this patient was involved in some trauma and we had consideration of the patient's C-spine, then there'd be a limited hyperextension of the neck and we might need someone to manually stabilise the head while we achieve positioning. Alternatively, if this patient was obese and we had to ramp them up, that might involve lifting the back of the stretcher for the patient or positioning some towels under the shoulders. The sniffing position for a paediatric patient would be different. They have a large occiput and therefore we need a pack underneath the posterior shoulders to achieve the same sniffing position. So the next thing that we need to consider is an assessment of the difficulty of intubation for this patient, and that involves running through a Lemon assessment. The Lemon assessment was designed for patients that are conscious prior to going into surgery, in which case the anaesthetist can come and evaluate the patient a little bit better than we can in a pre-hospital setting when the patient's unconscious and there's time-critical factors involved. But the Lemon assessment starts with looking externally. So these are for things that may affect intubation, such as a large tongue, large teeth, short neck, a small mandible, facial fractures or other forms of trauma. We're then going to evaluate using the 3-3-2 rule. So this is 3 of the patient's fingers to check the amount of mouth opening that we've got. And this just involves, is there enough mouth opening that we can pop the laryngoscope in the tube in the patient's mouth. We're then going to look at the distance from the chin to the thyroid bone, 3 of the patient's fingers here. And this just allows us to see whether we can displace the tongue and achieve a good view of the cords. And then the 2 of the patient's fingers would be the laryngeal distance in this patient. We're then going to check for the patient's Mallampati score. The Mallampati score relates directly to the Cormac-Leane views for laryngoscopy. It's pretty much how well the mouth can open and how well we can view the posterior structures of the mouth. Obviously this is not indicated in an unconscious patient, but a grade 1 view would be a good view of the glottic region, and grade 4 would be a poor view or no view. It may change how you intubate the patient. It might be better to intubate with a bougie to start and a patient with a poor view. O stands for obstruction or obesity. Things that can cause obstruction are things like swelling or deformities to the area, A patient that's obese is going to have lots of subcutaneous tissue, and this is going to reduce how well we can manipulate their airway. Things like airway burns can cause significant swelling and problems for intubation. And then N just stands for neck mobility. So we're looking at things like arthritic changes, or whether we need to immobilize the patient's neck, and therefore we need manual stabilization, as we've already mentioned. The next thing to consider is pre-oxygenation. For this patient in cardiac arrest, there's no role of pre-oxygenation. There's no blood pressure to circulate an FI 1.0 around this patient, so a fraction of an inspired oxygen of 100%. Pre-oxygenation would be indicated in an RSI setting, and this would be high concentration O2, so the fraction of expired oxygen 100% for 5 minutes, and this builds up a reservoir so that it allows for an apneic period while we try to tube the patient. So the next thing we need to do is prepare all of our equipment for intubation, which we have, and we're going to check that all of our equipment's in working order. So first thing I'm going to do is take my tube, which I'm going to use for this patient, with a pre-attached syringe, check that the pilot balloon inflates and that the cuff has no leaks and it's got a good seal, which it does. Then going to check that my laryngoscope, 1, locks in place, which it does, and 2, that the light works on it. I have then prepared all of my other equipment. So to start from this side, I've attached my filter, my end-tidal CO2, my COBS connector to the bag mask, which is then connected to the oxygen. This is going to be put on the tube as soon as it's in place. I've got a Thomas tube holder to secure the ET tube in place once I've got it in. I've got my suction on my right hand side, the left hand side is reserved for laryngoscopy. I've then got a size 8, 7 and 6 tube in case I wanted to change anything. I've got a stylet which I'm going to use for this intubation with my size 7 tube. I've got a Macintosh 4, a Macintosh 3 and a Miller blade in case I wanted to change something with the blade size. I've got a bougie in case I had a poor view initially, or I wanted to try my first pass with a bougie. I've pre-lubricated my tube ready for intubation. Over here I've got some alternative airway equipment. So this is an LMA a size 4, which is applicable for this patient. I've got a cricothyroidotomy kit ready in case I need to cric this patient. I've got my personal protective equipment, so the bare minimum that I'm going to have is some gloves and some safety glasses. I've got my stethoscope, and this is ready to auscultate the chest to check that I haven't intubated the right main bronchus, and to auscultate the stomach as well to double check that I haven't intubated the esophagus and I'm achieving stomach distension. So I'm now ready to intubate this patient. I'm going to take my stylet, insert it into my size 7 tube, which I'm going to use for this patient. I've got my syringe pre-attached. I'm just going to leave my tube here in the meantime. I'm going to take my laryngoscope in my left hand and I'm going to insert the blade from a rightward angle, sweeping left to displace the tongue. I'm then going to lift away from me towards the ceiling in the opposite corner of the room, and avoiding fulcruming against the teeth. I've now got a grade 1 view of the cords. So I've inserted the knob of the tube into the vallecula. So this elevates the hypoepiglottic ligament, or depresses the hypoepiglottic ligament to expose the vocal cords by raising the epiglottis. I'm then going to take my tube and pass it from a right hand motion down through anteriorly into the vocal cords, observing it pass through. I'm going to pop the cord into 23 at the lips for a male, 21 at the lips for a female. I'm going to remove my laryngoscope, keeping hold of my tube. I'm then going to remove my stylet, hop on my capnography equipment as fast as possible, inflating my tube. Then going to secure my tube with my Thomas holder. Then going to confirm that I've got placement of the tube, so I've got visual confirmation of the tube passing through the vocal cords. I'm now getting a capnography reading. I'm going to auscultate the chest as soon as possible, auscultating the right side first and then the left side to ensure there's equal bilateral air entry, and I haven't auscultated the right main bronchus. And then going to auscultate the stomach last to ensure that I haven't intubated the esophagus. The gold standard is my end-tidal CO2 reading, which I'm going to get from the patient. So just lastly, it's good to mention our alternative approaches to intubation. So alternatively to start, we've got the Miller blade, which we can use. These work quite well for obese patients or pediatric patients. The blade is intended to be passed posterior to the epiglottis to lift it directly to expose the cord. So instead of lodging into the vallecula, you're lifting everything anteriorly. We can also use a bougie. So a bougie can be used in circumstances of poor Cormack-Lian views, or whether we think that this might be a difficult intubation. It can just also be used for practitioner preference. The bougie achieves the same 35-degree angle that the stylet achieves, but it allows us to pass it without the tube in place. So just to demonstrate, we can insert the laryngoscope from a rightward sweeping motion, displacing the tongue left. I've now got a view of the cords, or if I didn't have a view, so I've now got a view of the cords. So just to demonstrate, I'll take the bougie, I take my laryngoscope, insert it in a rightward sweeping motion to the left to displace the tongue. I then insert my bougie and feel for the clicks on the cricoid rings. I can then railroad the tube over the bougie, and this is normally done best with an airway assistant, which would involve passing the tube over the end of the bougie, railroading it down. Interestingly, here, to pass it through the vocal cords, it might involve a rightward twisting to pass it through. Yeah, that's just bougie intubation. We can also pigtail the tube like so that we can hold it all together and intubate like this with the bougie. For a failed intubation, it's best to come out and change something. So if that would involve changing the positioning, changing the blade size or type, changing the tube size, changing the introducer, so whether you're using a stylet or a bougie, using an assistant. The assistant may be able to apply some burp, which is backward, upwards, rightward pressure. You may be able to use the laryngoscope to view the cords, and then if you don't have a view of the cords, manipulate the airway assistant's hand until you have a good view, and then get them to hold and maintain that position whilst you pass the tube.